of Mero Eye team. I'll be hosting the current session, and I extend a very warm welcome to each one of you who have been connected with us through our iTalks webinar. Also, I would like to thank you all for taking the time out from your heavy schedule and marking our program with your glorious presence. Thank you for joining with us this evening, and also don't forget to subscribe our YouTube channel for being updated to our programs even in the upcoming days. For now, I would like to step forward to inaugurate today's session, and also I would like to notify you all that we will be having our discussion session at the end of the webinar. So if you get any queries in between the session, you can drop it on our comment section. We will get back to you later on. Today, as a speaking delegate, we have Dr. Marc all the way from USA, who will be talking on topic vision therapy, a foundation on which to build. Before he begins, I would like to give his general introduction. Dr. Marc is an OD, MS, Fellow of American Academy of Optometry, Fellow of COVD, and a Fellow Distinguished Practitioner in the National Academics of Practice in Optometry. I welcome you, Dr. Marc, on behalf of Mero Eye Foundation and all our participants. So now it's over to you, Dr. Marc. You can begin your session.
Okay, I was just checking. Good morning, everybody. Or sorry, good morning. It's good morning here in Memphis, Tennessee, in the United States. And I guess it is evening, 8 o'clock or 7 o'clock in the evening in your neck of the woods. I hope everybody is doing well and they are safe, and hope to see everybody soon in person and give everybody hugs. So what we're going to be talking about, we're actually going to be splitting this into two different talks. So for the first, we're going to be covering some basis of VT and just give some general sequencing on how to attack certain problems, give you some general ideas, and then we'll start getting into some techniques, some basic techniques. Some have very low costs. Some are more computerized techniques, some of the more high-end stuff. The beautiful thing about vision therapy is that you can do, it's not the piece of equipment that dictates the outcome. It's the patient, it's how you use whatever piece of equipment you're using to have the patient gain the understanding that they are in control of their visual system and they're the one controlling the activities, not the piece of equipment. And then finally, if we do have time on the second talk, I'm going to present a few cases, some interesting cases, and how I attack them, how myself and my students and residents attack them in vision therapy. And I know you guys are on Facebook Live. Unfortunately, I guess I'll give my email address. If there are any questions, you could always email me questions. My email is mtaub@s as in Sam, C as in Charlie, O as in Oscar.edu. So if there are any questions that come up, just email me. So in vision therapy, the first thing you should learn is that there is no one way to do VT. There are, not an old joke, but it's one we make. If there are 10 VT docs in the room, you're going to have 13 ways of doing VT. What I do on a Monday, I may do differently with the same patient on a Friday, slightly. The overall sequence is going to look the same though. So you can have VT plans that are goal-based. For example, you have a patient with a binocular vision issue and they are suppressing. So maybe the goal is going to be to break suppression, or in this case, achieving sensory fusion. If you have a patient who has an ocular motor issue, maybe your goal is going to be pursuit movements. For amblyopia, it reduced improving visual acuity. and then improving accommodation and binocularity. So those would be goal-based. I'll say skip grid-based because that's, for me, the most important one. But then diagnosis-based. So there are several textbooks out there, and one of the things that I hesitate to do is I don't love the concept of saying, well, I'm going to do my sequencing for a convergence insufficiency versus a convergence excess versus an accommodative issue. To me, it's more logical to group them in areas of diagnosis. Because if you think about the difference between, the first bullet there, the CI, CE, AI, accommodation and vergence is linked intimately. And I would say it is impossible to treat one side of the equation without looking at the other. And even in treating CI versus CE, you want to train both, divergence and convergence. You want to treat both accommodative stimulation and relaxation. So to me, it doesn't necessarily make a lot of sense to say, I'm going to put in my CI protocol. You want good flexibility on both sides of the equation. Another option would be treating it should be ESO versus EXO. There's the typo in there. So to me, I don't necessarily treat these very differently. Why? Because atropia is not, there are some cases that it is, but most of the time, atropia is not a muscle issue. It's a brain issue. And in VT, we are training the brain to essentially get control over itself and get control over the system. And we train it the same way. They're still the same skills, learning where the eyes are in space, learning where you are in space, coordination of hand-eye movements. They're all the same in ESO versus EXO. The one that I subscribe to is a grid-based system. Let me just see what my next slide is. Okay, my grid-based system. So I have taken most of the OEP courses, and what I love about that system is that it groups diagnoses. So based off of essentially 3 or 4 categories. First one being basic binocular. So those would be your CIs, CEs, accommodatives. But it treats them all the same. Next one would be learning related vision problems. Those are going to be your processing issues and your ocular motor issues. The beautiful thing about this system is that it builds off of the basic grid of binocularity. So just because a patient has a processing issue doesn't mean we don't want to strengthen what is hopefully already strong, which would be vergence or accommodative. And it is likely that there are multiple problems in the same patient. So if you've got a CI, you might also have some visual processing issues and a tracking issue. So we can work them all in that same grid. The next one would be strabismus and amblyopia. Working on a greater amount of trying to break that suppression that is most likely there, improving acuity, an amblyopia through binocular treatment, no patching. And then we also have several 2 grids that are a little bit more specific to traumatic brain injury. So the beautiful thing is, and I can't show it to you, I'm sorry, it's not my work product, and it is copyrighted, so I cannot show it to you. But the beautiful thing about this system is that it makes it easy for me as an educator to teach my students in that, you're doing this activity for this amount of time, and there's certainly flexibility. If the patient, does really well in it, that means you're going to move on quicker. You can turn up the burner a little bit and make the activity more challenging. So there's flexibility. It's not on week 1, you must do this. Week 3, you must do this. Week 5, you must do this. There's flexibility in that system. So what are some of the things that you must consider in doing VT? You know, so much of what you can do depends on the patient. You'll see down there, it says patient's age, developmental age, cognitive impairment. If you have a patient who has a strabismus and they're 8 years old, you're going to be much more limited in what you can do versus a strabismic that is 12 or 13 years old. Just there's a better cognitive understanding of what are some of the things that we're trying to get them to realize in doing some of these activities. Always have to keep in mind the goals. If the child is not, child and parents or guardian, if they're not on board with doing VT, getting the child there on time, the child has no desire to do the homework, they don't see the benefit of what they're doing, your ability to treat them is going to be very limited. What are some of the physical demands? When I'm treating patients with traumatic brain injury, many of them are physically impaired. They cannot get up and do any of the balance activities. Of course, they're going to be much more unstable. They may not be able to get out of a wheelchair. I just move my little thing here. Thinking of the visual demands, what is the patient doing in which this problem is limiting them? So you always want to try to incorporate the best you can, whatever if it's profession, if it's school, activities that you can take the VT and translate it into their real life. The available vision therapy equipment. I am very lucky, I know that, in that I've got so many toys to play with. But strangely enough, I come back to my tried and true activities, the ones that I really like. So I wrote an article for Review of Optometry several months ago, for Optometry Times a few months ago, about different things that I've learned along the way that I wanted to pass on. And the first one of the first ones was start with really basic VT equipment. Learn how to use those really well. Then you can expand your repertoire. As I said, the affect and attitude of the patient. Again, if they're not on board and you've got one of these, mopey teenagers that comes in and or an 8-year-old who is a behavior issue, and you try and you can't get them to settle down at a VT, they're not doing the homework, I wouldn't tolerate it. I wouldn't have them in VT. If they're not willing to allow the process to be successful, then it's not worth it. Don't knock your head against the wall. I like to do as many activities as we can standing up and using movement. I do not do primitive reflexes particularly, but I use as much movement and as much action with distraction as possible. Take, for example, just simply doing the cover test. If you have the patient seated doing the cover test, you're going to possibly get a different result when they're standing, when you're activating the vestibular system. Maybe they're slumped over, maybe they're, who knows? And the same thing is in VT activities. So, I like to do as much as I can standing as possible. And then the timing and duration of sessions. I think the most successful therapy is done on a weekly basis. If the patient is further away, you may need to consider every other week but it's a very special patient. If you've got great parent support, it's an older patient who has mobility issues and getting them into the office is a challenge, you can consider every other week. I've done every once a month. using a home-based program called HTS, which is a computer-based, internet-based program. Then supplement with some home activities. But what I guess I've found is the more I rely on the parent and the patient to get their work done, the less it actually happens. It's almost a reverse trend. The ones where it's not that important, they seem to do it all you want. The ones that you really need to do it, they don't ever do it. So there's so much that goes into VT. Just on the patient and comfort symptoms, you have to be careful in you need to keep an eye on the symptoms. If the patient leaves your office wanting to vomit every time, I'm not so sure they're going to want to come back. So sometimes you need to kind of pull it back a little bit and weigh what are the benefits of pushing the patient too hard, too fast. It's just some more considerations. Always want the activities. It's really nice that they do well on the Coit vectogram, and it's really great that they can do 150 flips in a minute. But if then they get to the classroom or they sit down to use the computer and 10 minutes later things are going double and they still don't understand internally how to control that so it doesn't happen, you've lost the battle. In terms of therapy, I try to use as much therapy in real space as possible. There are activities, you'll see later, the Sanet Vision Integrator, there's the HTS program, there's the Right Eye. There's so many different things like that that have a computer screen. Well, the Sanet Vision is more, it's kind of in free space though. So like the HTS, the CPT program, and then there are programs all over, and I would prefer to teach convergence and divergence using lenses, using projected vectograms, using equipment that is as open as possible. Think about the difference between you doing your vergence ranges in a phoropter versus in free space. You get different results, and you're going to get different results in your therapy if you rely just on a computer-based program with without having that free space component. I'm very much not someone who, as I said, does diagnosis-specific VT. Very rarely, especially in processing, are you going to have somebody who does poorly on one aspect of processing. So you want a well-rounded program that encompasses all of the different activities and therapy skill areas. Probably one of the more challenging things to understand in VT is the concept of loading and unloading. Think about an activity, let's see, how about just basic eye movements? If you have a 5-year-old or a 10-year-old with special needs, their abilities are going to be different than a 15-year-old. So, or even going a step further, it's going to be different than an athlete. But within each activity, you can find their success level and then push them higher, or if they're not succeeding, drop them down a little bit. So let's get into some of the different aspects of VT. So you'll see here on the screen, so this is just kind of a conglomerate. You'll see that there's a whole nother screen after it. You've got, say you're treating ocular motor. So the book will say, okay, well, we've got fixation, pursuits, and saccades. With accommodation, you're treating accuracy, amplitude, and flexibility. The activities that you're going to do are not necessarily specific to one of these. Even take accommodative flippers. Well, you're treating flexibility, but that's also going to impact amplitude, and it's also going to impact your accuracy. If you flip that over and all of a sudden it's blurry, well, you're not very accurate and you're not very flexible. For anti-suppression training, monocular in a binocular field, it could be developing sensory fusion. There are several different levels of fusion, stereopsis being the highest. For fusion ranges, you've got a convergence and divergence. I will say that one of the things that I've learned over the years, and I've stepped away from doing it, is I was always taught to, like you go to the gym and you want to lift the highest weight, one time. Well, that's really nice, but if you then go and you try to lift a lower weight and you can only do 2 or 3 times, you want to, the analogy I'm making is more is not necessarily better. I would rather train them to be within a limited range that they need to succeed and be flexible in that range versus, bring them all the way out so they can go to 32 and Q on the vectogram. How much convergence and divergence do we really need? I'd rather keep them into a tighter range and have better control in that tighter range. And it's a more realistic range. For visual integration, the concept of bimming and bopping, when you're doing base in activities, use minus lenses. You're doing base out activities, combine with plus lenses. So you're all of a sudden, when you're doing a convergence activity, it's impacting accommodation and the opposite. So you need to have good flexibility and understand the impact of one on the other, both you as the therapist and you as the patient. For sensory motor integration, these are going to be issues with lefts and rights and understanding directions, just gross motor coordination. You throw a child a ball and it bounces off. They just have no concept of their sensory motor system. Sensory integration, anytime you're bringing any other sense into it, whether it be tactile, whether it be vestibular, auditory, speech, that would be Skeffington's 4th circle. And then vision processing, kind of the amorphous vision processing. So let's go through a little bit of some of the areas. So for ocular motor, so this is a whole long list of stuff that we want to accomplish. The key, and I put this, I think, on each of the slides in different areas, the key is to getting the patient to point their eyes where they think they're pointing them. So you always, the sign of a good vision therapy activity is that one that includes some sort of feedback. So on your ocular motor training, when you're doing a pegboard rotator and you're following it along and you've got a golf tee and you're trying to stick it in one of the holes, what's the immediate feedback that you're not looking where you think you are? Well, if you try to put that peg in and it doesn't go in the hole, that's immediate feedback. So a good therapy activity must have feedback. One of the things I do love about some of the electronics is that there's an auditory feedback. Most of you don't know an activity called the talking pen. The talking pen was around in the 70s, 80s, and 90s. And essentially, when you were following along with this electronic pen, it was quiet. But when you went off the line, there was an immediate sound that signaled it to you. So now all of a sudden you got a visual motor feedback. In ocular motor, it's easy to have feedback. When you're doing an activity called stick and straw, where the patient is trying to stick a pickup stick into a straw, immediate feedback, they don't hit the target. So bringing in some sort of feedback is very important. I'm not going to sit and read all of these to you, but I will say, obviously you want to develop really good eye movements from fixations to pursuit to saccades. The key on ocular motor is you want to integrate it with everything else. Obviously, if you're tracking something and it's a letter target or whatever, there's going to be some accommodation. If it's moving in the z-axis, there's going to be convergence and divergence. So the key on any of this stuff is integration. For accommodation, I think the key is, what does it feel like to accommodate? What does it feel like to be on the right plane at the right time and space? If a patient can't, you can do as many flips as you want, but if they don't internalize it, what does it feel like to focus through A+2 and for it to be clear? Because in theory, one of the activities we'd love to do is have them do the same activity without the lenses in place. There's an activity called minus lens to blur, where we're learning with a lens in place to blur. But then we clear it up. That's simplifying it. So on accommodation, one of the big differences is for me in many therapies is the understanding of feeling, whether it's accommodation or vergence. And we'll talk about that in a second too. But you'll see all the way down, normalize with accommodative convergence, integrate processing. So wherever activity you're doing, you need to integrate all of the others. To me, that's why a grid-based system really makes sense. Binocular vision. What does convergence and divergence feel like? The number one activity everybody loves to do is the Brock string. The Brock string is a key. It's so simple because there's immediate feedback. The mistake people make is, say you've got a convergence insufficiency. You put up a bead, and the first thing you do is, oh, let me take that bead and move it closer. But if the patient has no concept of what does it feel like to understand the concept of physiologic diplopia, I look here and back over there is going to be double, or in front of me is going to be double. You've got to have that concept first. If you don't have that, Brock string's not going to be successful. But having them have an understanding of what does it feel like to converge or diverge way before you do the Brock string is going to lead to a more successful treatment, more successful therapy activity. If the first thing you do is week one, they've got a CI and you say, okay, here, do this Brock string. And you get to out over here, it's 2 feet away. Oh, well, converge, just do it. But they don't even have a concept of what is it feeling, what is that feeling like? So, and again, any activity, whether it's, and some of these are some of the basic activities in every grid that I use, is getting that understanding of feeling. For a strabismic, for example, using a large amount of prism to send their eye the opposite way. So they feel like, if they're an esotrope, what does it feel like for them to be an exotrope? What does it feel like for their eye to actually be the opposite way? If they can understand the opposite way. Can somebody mute themselves? Thank you.
Doctor. Sorry for that.
That's okay. I get distracted easily. Convergence and divergence. But again, you're seeing all of this accommodation on the bottom, accommodation convergence, integrate with processing. For amblyopia, I don't personally use patching in my amblyopia treatment. If our goal is binocularity, why would we start with putting a black patch on? I want to do everything that I can to spur on binocularity. We try to normalize visual acuity the best we can. If we give them the opportunity to learn how to use both eyes, because amblyopia is more than acuity, it's accommodation, it's processing, it's contrast. If we give them the opportunity, again, because amblyopia in most cases is not an eye thing, it's a brain thing. For strabismus, the ultimate. So you see accommodation, you see ocular motor, you see vergence, you see stereopsis, you see processing, you see all of these things. Strabismus is not just about making the eye straight. It's about integrating accommodation, vergence, eye movements, processing, acuity, really, getting at the heart of those things. For processing, processing is everything. Processing is not just, to be integrated with. Processing is laterality and directionality, discrimination of objects, including size and shape and color and thickness and orientation, figure ground, form constancy. But again, it's really nice to be able to do those activities in the therapy room, but you need to bring those out into the real world. It does nothing if your therapy doesn't meet the patient's goals. And in many cases, the patients and the parents' goals are to do better in school. So you need to translate that. Even more stuff for visual processing. So I think we've got about 9 to 10 minutes. So the concept of loading and unloading. This is one of the most important concepts. So, for example, we took I think I only have, I gave a few of these. So think about large eye movements. So you have a patient who, I'm just going to sit back for a second. You have a patient who is a 5-year-old, all over the place patient, and you ask them to do eye movements. And the eye movements are, in a circle, just a basic circle. And they're doing, do all that kind of stuff. And there's body movement, there's head movement, and the eyes are not moving independently in the head, and the body is, all moving together. How do we get them to understand the concept of moving the eyes separate from the head and the body? Well, hold on a second. So, if we want to decrease the difficulty, if they are, say they are standing up, well, let's take gravity out of the equation. Let's have them sit down. Well, what if we're still moving? Well, then let's have them lay down. If we have them lay down and instead of going in a circular pattern, imagine the child on the floor and you're just swinging the ball back and forth. What if even that is too challenging? Instead of swinging the ball back and forth, you can make the ball larger and do small, slow eye movements. Most of the time, faster is more difficult. So let's slow those eye movements down. What if even if that's too hard? You may need to put your hands on the child's head so that they have the feeling of moving the eyes without moving the head. What if the activity is too easy? What if you have an athlete? What is the making it harder? Well, you could put them on a balance board. It's a board with a square peg, and have them do eye movements while balancing. You can do eye movements while walking on a balance beam. You can have eye movements with multiple targets. You could integrate eye movements with the metronome. So that's, some of the loading is very important. In the environment, for anyone who treats children on the autism spectrum, having them in a small room, in a quiet room, without clutter, no pictures on the wall, a nice calm space will go a long way. But what about if we're trying to make it more challenging? Again, go back to the athlete. What if you have the athlete? Of course, today, most athletics is taking place without spectators, but in the normal world, pre and God willing, post-COVID, get them into a group space, background noise, background music, increased distraction. If they can perform the activity with more distraction, you're making it at a higher level. So for lenses, say, for example, increasing difficulty. So it says here, use smaller increments between lenses. So if you're doing an activity, there's an activity called lens sorting, where you dump out a bunch of trial lenses, plus and minus, and usually start with about +1 differences. You separate them into plus and minus based on what does it look like and what does it feel like when you put this lens in front of you. You then separate them out, and then you have the patient put them in order of from lowest to highest. You can make that activity harder by using smaller increments, smaller noticeable differences. That's going to make that harder. You can play with getting closer to the patient versus to the activity. Obviously, getting closer to the activity, then you're going to have to converge more. Getting further away, you're going to have to diverge more. And you can also increase difficulty with, say you're doing a Brock string and you want to make the activity easier. Well, what's going to stimulate convergence? Stimulate convergence, a minus lens. So there are different ways to use what you have in your practice without needing to go too crazy. So let's see. I've got probably 3 or 4 minutes. Is that correct? And then we'll do some questions.
Yeah, doctor.
Okay. So let me introduce. Hold on 1 second. Let me see how far I can go. Go back. Sorry, my computer got stuck. So I'll introduce 1 or 2 activities. So the wolf wands. So there's an activity, and you don't have to use the wolf wands. You can probably make whatever you want. What I like about the wolf wands is that the balls are reflective in nature. And we talked about having that feedback. With the balls being reflective, if you can see your reflection, obviously you're looking at the right place. If you don't see your reflection coming back, then you're not looking at the right place. So you're getting that feedback. So you can use these in just simple eye movements. But before I do that, I like to do an activity called eye control. Eye control gets at the heart of where are my eyes pointing in space and what does it feel like? So you take one of these wolf wands and you start off with the activity, it's unpatched, and just simply put the wand in front of one eye as close as you can. So imagine this is my eyeball. I'm literally this close to the eye. If you're further out here, you can do it yourself. Put your finger really close right under your eye. You should feel significant tugging and pulling, versus out over here, you're not feeling that. So eye control is not necessarily an accuracy thing, but it's more of a if my eyes are pointed where I want them to be, how does it feel? So it's giving the ability to get an understanding of giving that feedback for where my eyes are. And it's where the eyes are pointing in relation to the body. Because if you put the wolf wand to the side versus to the middle versus up and down, they're gonna feel different. The key is working with the patient to get them to understand what they feel like. And say you have a strabismic. If you have an esotrope, obviously, the wolf wand nasally on the strabismic eye is going to feel different than it is on the non-strabismic eye. So getting them to understand those differences and to feel those differences is absolutely important. You can also do this activity with movement using a metronome. Boop, 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 boop. So that you're now working on what does it feel like? You're working on fixation, but you're also now working on integrating the sensory system, the auditory system. So it's a great activity. And one of the number ones that I start off with every single patient. And this is actually one that I take into the rehab facilities working with TBI patients. Because so many times they have fallen back down the developmental scale, and even having a basic understanding of where their eyes are pointing is very challenging for that patient population. And I think that actually might be where I'm going to stop today. So I gave you a little bit of a teaser for next time. For all of the different activities, there are probably 20 of them that I'm going to go through. So now I guess it's question and answer.
Thank you so much, Dr. Mark, for such a wonderful session. Now we are to move to the another session, that is discussion session. Are you ready to take the questions, Doctor?
Sure.
Yeah. I'll be reading out the questions for you.
Okay.
Okay, let me check out the questions that our attendees might have raised. Okay, our first question goes as we know, main aspect of vision therapy is home-based with guidance in our office visits. Can you share some insights how to improve that from the therapist side, especially in the perspective of importance of instructions to be given to the patient and selection of tools to provide for home-based activities?
Well, I think, home-based activities, I think I was clear. I don't believe home-based activities overall, unless the patient is very special, unless the parent is very involved. I'm always suspect of doing more at home than doing more in the office. Therapy takes time. It takes an understanding of how to load and unload. And parents are not therapists. They're not doctors. They're not trained therapists. And there's a lot of subtlety that comes with doing therapy in the office. There are some activities that I will send home after I have done them in the office, like eye control. But the key is you have to have a printout. You have to have instructions as to what the goals are, what the steps are in the activity, and if you're altering them based on loading, unloading, you have to make those changes. Bring the patient into the parent into the therapy room and get them to see the activity, and even if you have the opportunity, get them to do the activity in front of you so that you can correct what they're doing. But again, I think most of the therapy has got to take place in the office first before you could ever send it home.
Okay, thank you for your answers, doctor. Okay, this is only the question that I have seen on our chat screen till now. If you are having any queries, then you can come up with your questions on our chat box. Dr. Mark will be happy to answer all your queries. Okay, doctor, we have again another question. As you discussed the different aspects of BT, should that always be in chronological orders to treat?
Um, yes. I mean, the analogy would be riding a bicycle. You can't learn to ride a bicycle without training wheels. So you start with you start with the parent holding on, and then the child starts to learn with training wheels, and then you take the training wheels off, and maybe they ride in an open field, and then on the street, and they get further and further from home. It's the same thing with therapy. You have to start and build a strong foundation before you can go several steps up and build the top of the tower. So I, regardless of who the patient is, I always start with the basics, and I use the concept of loading and unloading to get them where they are to the right place. And then I keep loading and loading and loading and loading to find that point at which I'm going to start the activity. But I always start with the basic activities. I don't assume that just because the patient is a graduate student doesn't mean that they have any understanding of how their visual system works and that they're using their visual system in an efficient manner. I actually have the assumption that they're not.
Okay, doctor. Mr. Moniz Tahal has addressed that. Hi, Dr. Taub. Good morning. It's always great hearing from you. He has mentioned us to convey his regards to you, doctor.
How are you? Good to see you. Yes, I can't see you. Good to hear from you.
Okay, doctor. I will read out the next question. Please explain about amblyopia management and therapy.
What was the amblyopia management?
Yeah, doctor.
So, the long-standing the quote-unquote evidence-based approach brought to us by the PETA group relates to using patching, atropine, and filters to lower the acuity to a certain level, and then essentially we have our acuity is now close. We are now successful. But anyone who does VT can identify that just because acuity is 20/30 and 20/20 doesn't mean that the brain is putting both of those images together and processing that information properly and efficiently. So any therapy has got to come with, any amblyopia therapy has got to come with eye movements, accommodation, vergence, processing. What better way to start to embed better visual behaviors than having the patient learn to use their binocularity as that acuity starts to drop in your therapy process. If you give the brain a reason to see clearer and to process the information out of the bad channel, it will do so. So early on in my career, I would do more patching. That's what I was taught. That's what the protocol is. I don't do patching anymore. I would rather use contact lenses to get the clearest image and then get them right into therapy, start working on monocular skills, start working on accommodation, fixation, eye movements, but then also start working on binocular activities using both eyes. Obviously, amblyopia is going to be a little bit harder if you have a strabismic component, but again, once they have an understanding of where the eye is pointed, I think you'll find success. And I do see another question. For those wanting to start a VT practice, can you share some insights? Is that the next question?
Yeah, doctor.
Okay. So in the article, if I put the article link in, can you send that out? I guess, can we get that out to everybody? That's a question for the host.
Sorry, doctor, can you please mention once more?
If I have an article that I want to send out to everybody about some insights that I have, is it possible to get that out to everybody?
Yeah, it is.
You can share the link on the chat group, and I'll be sharing to the discussion group. You can share on the Zoom chat group.
Okay, hold on. Let me see if I can find it.
Hi, Marc.
Who's that?
Manish here.
Oh, hi, Manish. How are you?
I'm good. How
Oh,
are you?
I didn't see your picture. It's hiding behind stuff. How are you, Manish? No data. Huh. I'll find the article that I want, and I'll send it to you. It's kind of the things that I've learned in terms of just to be a successful VT practitioner. And one of the things in terms of starting a practice is to, there are two things. Start with basic equipment. Don't go out and try to buy the fancy stuff. Start with the basics. Lenses, prism, Brock string, some basic tranaglyphs. You don't even need to get into the expensive Polaroid stuff because that's more expensive than the tranaglyphs. Start with really basic stuff. You don't need the fancy computer stuff. You don't need the big screens. Those are the fun things that the kids, they like to play with. But the best, even a chalkboard or a whiteboard, you can do successful therapy with a pencil and a lens. You can do that. So start with inexpensive equipment. The next thing is don't start with a 7-year-old autistic or a 35-year-old esotrope that has never seen stereo in their life. Start with the basic patients. Start with convergence, accommodation, and eye movements. That would be my two suggestions for starting a practice. And communication. say you're seeing a patient and you say, well, you know, you're going to need vision therapy. They go through, you can send a letter or communicate with their pediatrician, their primary care doctor, whoever it is. If they have had a stroke, communicate with their cardiologist, communicate with their neurologist. A letter costs just the cost of a stamp. It is worth your time. Sometimes the doctors don't know you exist, but if they've sent you a patient, you want to communicate back. So there's no such thing as too much communication.
Okay, doctor, we have another question, and the question goes as, what is SILO and SOLI effect in VT?
Ooh, okay. So when you are, so essentially the concept of silo and soli. So this may be more complicated than I can do on the chat group. So when you're doing a vectogram, so there is a natural tendency for your brain to think that when something is getting closer, it should be getting larger, right? But when you're doing vectograms, it's actually the opposite. So when something's coming closer, it's getting smaller. It has to do with the visual angle and all of that stuff that we, you know, but I'm not going to get into that. So the hardest thing about silo and soli, which would be the opposite, is for older patients who who know something should be getting larger when it's coming closer, getting them to trust their visual system in their brain can be a challenge. But if they cling to what they think they should be seeing, therapy is going to be harder. So you really need to work on, and there are some skills that you can do to get them to understand the concept of silo, which is what we want, which is what the brain is seeing. But you need to get them to understand the concept of silo before you can move forward to be successful. Some places will, some sources will say, whether they see silo or soli, just know that those are the responses and go with those. I disagree with that. You really need to work on having them see silo and not see silo, but appreciate silo before you can move on to higher level activities.
Okay, doctor. Thus far, these are only the questions that has been raised by our attendees. Thank you so much to everyone for coming up with your questions and making the discussion session more interactive. We will be waiting for just a few minutes. If anyone is willing to ask anything, then we will close the today's discussion session. Okay, we have answered almost all the questions till now that has been popped on our chat screen. Considering the time limits, here I announce the closure of discussion session. I would again like to express my immense gratitude towards Dr. Marc and to all the attendees for their endurance. Also, I would like to thank all the direct and indirect helping hands for the ITEX program. Before wrap up, I request our today's presenter, Dr. Marc, to share his few words to our program. Over to you, Dr. Marc.
Yes, I'm sorry, I was looking.
I request you to share your few words before wrap up.
A few words. Well, we're going to be talking again in 8 days. So everybody have a good week. And in terms of vision therapy, don't be afraid of vision therapy. Get some basic equipment and start treating patients. That's all
Thank
you
you
have to
so
do.
much. Thank you so much, Dr. Mark. It was our immense pleasure to have you with us today.
My pleasure. I'll see you again in 8 days.
Yeah, we will look forward for your session. You're with I